common peroneal nerve branch today, and also about something called double crush syndrome. Just to define common peroneal nerve, it's a branch of the sciatic nerve. Sciatic nerve is back here in the hamstring area and right above the knee. The sciatic nerve divides. One branch goes down the back of your calf. It's called the tibial nerve, just like the tibia bone. The other nerve branch comes around the outside, like so, and it's going right over the fibula. You can feel the head of the fibula, where the fibula ends right there. That little prominence is the fibula head, and right beneath the head, there's kind of a, it's not really a groove, but it's just a recessed area of the bone, and that's right where the common peroneal nerve courses from back here. It goes around the fibula, and then comes through a tunnel there called the common peroneal nerve tunnel, and then pretty much common peroneal nerve supplies everything on the top of your foot. Okay. No, and I might mention too, it supplies 5 different muscle groups up here, higher up in the leg, that allow you to pull your toes up, your foot up, and your foot sideways, which will go in another video or another time. But the point of this video is something called double crush syndrome. So this is an interesting phenomena. A lot of people don't know about it. In the peripheral nerve world, we know about it quite a bit. And probably another specialty group that knows about it would be like neurosurgeons. They kind of know about this phenomena too. But all double crush means is that when you're looking at two areas, crush meaning compression, they kind of feed off each other. So, my explanation will help explain it better than anything. But what happens oftentimes, we'll have people coming in that have sciatic pain, which is pain, from hip joint area down to the knee. Or they may have sciatic pain and also some low back pain, okay? And that's how they present, but they also might present with some symptoms coming down here. Nerve symptoms, burning, tingling, numbness, what have you. Maybe they'll even have drop foot, okay? But the symptoms don't stop here. They're from here down, okay? So for what I'm going to tell you to help the patient, they almost have to have symptoms the whole length from back to the hip, to the thigh, and then down further. If it's just from here up, what I'm going to explain may not work. I got ahead of myself when I said that. So it'll make sense more in a minute. So what double crush simply means is if you have an issue in the back, like spinal cord area, maybe there's a nerve root or roots where the nerves are coming off of the back, and there's compression there. Maybe there's a disc that's bulging. Maybe there's arthritis spurring back there, but that's a site of compression. So maybe the neurosurgeon, maybe the orthopedic surgeon has already done an MRI, and they've looked at it and they can see it on there, and they're saying there's compression. They can see it, right? It's pushing on the nerve. And the patient comes into me, and I evaluate him, and I'm pushing right here, and or pressing, or I'm tapping, and it's very sensitive there. So that's called a Tinel sign, positive Tinel sign. So that's a clinical sign that they have compression. Okay, the Tinel sign idea goes back to World War I. It was described by a French doctor, Tinel. But so that's a very reliable indication of compression. So I'm saying by my exam, hey, there's compression there. The other doctors are saying from their evaluation with imaging, there's compression there. If there's compression in both locations, and I were to go in and get rid of the pressure here on the nerve, there's still pressure up there, undoubtedly. You'll take the MRI, nothing has changed, but the nerve is happier up there. It's not sensitive. So it's not as sensitive to the compression. It exists, but the nerve isn't as sensitive to the compression that's taking place in the back. And that is how, multiple times, not just me, but my colleagues, we're treating patients here, we're doing surgery on this nerve, and in our clinic here we do a fair amount of restless legs surgeries, and we open up one of the nerves, and we open up the comperennial nerve to do that. Or maybe the patient has a drop foot, and I find that they have compression here. I'm going to do surgery on the comperennial nerve to get rid of the drop foot. Or maybe they have neuropathy, and I'm going to open up the comperennial nerve to help with neuropathy. But the side effect is that they have improvement up there. Okay? I'll give you a story. A guy yesterday came in, Southern Colorado, found out about me through another patient I did surgery on. He has had back surgery. He's had nerve stimulator in his back. They put it in, didn't work, took it out. But he had surgery in his back. But he has trauma that he's had up here, but I don't want to get into trauma. But the bottom line is he has symptoms all the way from back, all the way down here. And we did an injection here. And from knee down, he's 80% better. And from knee up, he's 80% better. So that's when I do this injection. I'm going to show you in general how we do it, but it's called a Phoenix sign, and we don't know why it works, but we know it works. And we don't use any cortisone. We're just taking a half a cc of local anesthetic, and we're injecting it beneath the skin, but right above the nerve, and people get immediate response. So that's a very positive indicator that if you did surgery, the surgery should mimic the results that the injection gave them. Okay? So it's very emotional. Wife was crying. You were here. It's like, what? Because they go through all this stuff. And so it's important that you hear that, not to brag about myself, but it's just like, whatever. Healthcare doesn't know that. Everybody in the world is focused on, it's all about the back. And I'm going to say, I say this to patients all the time, the Tenel sign that we're able to, I would argue that a positive Tenel sign here is as important, or it's probably as reliable or more reliable, I'd argue, than an MRI of your back. Because there are plenty of people walk around, if you go outside and start pulling everybody in that's over 50 to do an MRI of the back, you'd be amazed. You know, there's lots of things to back up what I'm going to say, but there are many people that have MRI abnormalities of their lower back. They have no symptoms at all. So just because it looks like it doesn't mean the nerve is really damaged. But when you press or tap on the nerve and it's really sensitive, that's saying it at right this minute, that nerve is highly sensitive because of the compression that's right in that location. It's not very sexy, it's not very cool, it's not like getting imaging and all that, but it's a very reliable sign, and that's what we use in my world of peripheral nerve to evaluate. So hopefully that made sense. But we use the injection and as a diagnosis. Now, before this became very apparent, we would just, somebody has neuropathy, okay, we're going to open up comperennial nerve, and then say, hey, you know what, doc? Oh, by the way, it did help my back. It helped my sciatic pain. That's how we kind of first learned about it. Because believe me, we weren't looking at helping people up here. It kind of came over time from experience of doing surgeries. And in fact, before COVID hit, we actually had downstairs, we have patients that are in a study. We started a study before COVID to verify how well that works, but we're not doing that now because I just did a lot of stuff like that before COVID, and I can't do it anymore. It's just too much work. Okay, it's hard to do research and then try to run a practice at the same time. So I'm going to now show you just kind of roughly how we do this. So if we were going to evaluate her for this, I would have the ultrasound set up, you type in the name and all that, but I'm just going to show you what it looks like, and then we do this half cc injection. Now, the traditional way of doing an injection is just using local anesthetic cortisone, okay? And I once in a very rare time will ever do that up here anymore. I just quit doing it since this idea came about of just using half a cc of local anesthetic. But if you ever used like lidocaine and marcaine and dexamethasone here, and I injected quite a bit, we always used to have people leaving with a cam boot on, because if you put that much volume here, you're going to bring the nerve up enough that they will have a drop foot. They won't be able to pull their foot up into the side temporarily, and they need to be in a cam boot until they get their strength back. Okay, so just so you know that, in case I did a regular old style cortisone injection. So let me just kind of show you what this looks like. so so when you're looking at this, that dark mound is the, I'm gonna try to just used to looking at it like this. So that's the head of the finger, that's the bone. And then if I come right there about 12 o'clock, let me try to freeze it. So I can show you if you can freeze it. Can you reach over there? Wait 1 second. Okay. Yeah, freeze it. Yeah, that's the nerve right there. It's good. When you're looking at nerve, the white is the nerve tissue itself. The little fascicles are called in the nerve, and then the dark area is the myelin, the fat. Fat is dark, and nerves are white. So it has kind of a salt and pepper look. So if I were to inject her, I would have the ultrasound, you'd spray, and then what we're trying to do, we're trying to target and put that half cc right there, right above the nerve. Both beneath the skin, but right up above the nerve. And that's the goal, okay? And again, just so you see how I look for this, I find the landmark first, which is the fibula bone. And then I'm right on it, and then I'm just sliding down a little bit more towards your foot, and then it starts to reveal itself. And there it is again. Right, kind of at 12 o'clock. Okay, so that's that. So when I did that injection on this person yesterday, I had another one yesterday. She said, I don't know why I brought it up, but she just said something about, she's coming in for warts. She's been coming in here a long time for warts, and she said something about what's happening in the next couple of weeks. She said, I might be having back surgery. And it's like, oh really? Back surgery? Okay, so what happened to your back? Well, I don't know, but 6 months ago I really started hurting. And so she said it's not my back even, I'm getting pain down my left leg. So I was like, really? And so I checked, and she had a tenel sign on her common perineal nerve. We injected her common perineal nerve, and same thing. She had huge response to that, but nobody had looked at that. And she wasn't even having back pain. It was more sciatic pain and everything that followed. So we'll see where that is. I do have some people out there that have had back pain. They've had sciatic pain. It's not bad enough that they do surgery, but I've done the injection, and they know that if they elect to have a surgery, oh, well, maybe they would do this instead of that back. So at least they know they got that other option. And if it fails, you can always do back, right? But back surgery, I'd argue, probably has higher complication rates and redo rates and things like that. So, I think there's anything else to mention about it, but it's not a common known phenomenon, and it's lots of fun to do. Like the guy yesterday, he could only lift his leg up. I mean, I don't know if he's probably goes up 70 degrees when he's laying back. It's a test for sciatic pain. It's really painful, but maybe it's like a ballerina. I mean, he can whip it straight, like up to 90 degrees off the table when he was done. So he'll be coming in this morning. But anyway, that's it. That's really what you need to know about double crush theory, and the common perineal nerve.